The intrapartum period begins with regular uterine contractions and ends with delivery of the placenta. It includes all stages of labor and birth. This period is divided into 4 stages: cervical dilation, pushing and birth, placental delivery, and immediate postpartum recovery. Nurses monitor maternal vital signs, assess fetal heart rate, provide comfort, and watch for complications. For the NCLEX, know the normal progression of labor, recognize deviations, and understand essential interventions. Mastering intrapartum care is essential for safe, effective nursing and NCLEX success. Stage 1 of labor begins with regular uterine contractions. These contractions thin and open the cervix, called effacement and dilation. Effacement means the cervix shortens. Dilation means it opens to 10 centimeters. Stage 1 ends when full dilation is reached. This stage has 3 phases: latent, active, and transition. Latent phase, mild, irregular contractions. Cervix dilates up to 4 centimeters. Active phase, contractions intensify, dilation progresses from 4 to 7 centimeters. Transition phase, strongest contractions, cervix dilates from 8 to 10 centimeters. Key nursing interventions: monitor mother and fetus, provide pain relief and support. Encourage position changes, hydration and breathing techniques as labor progresses. Labor is shaped by 5 key factors, known as the 5 Ps: passageway, passenger, powers, position, and psyche. Let's focus on the passenger, the fetus. Fetal presentation describes which part of the baby enters the birth canal first. The most common and safest is the vertex presentation, where the baby's head is down and flexed. Breech presentations occur when the baby's buttocks or feet are positioned to come out first. There are several types: complete breech, frank breech, and footling breech. Only complete breech and frank breech may be considered for vaginal delivery if conditions are right. Footling and other breech types usually require a cesarean section for safety. Here's a quick summary: breech types that can deliver vaginally, complete and frank. Breech types that cannot, footling, incomplete, and others. Remember, the ideal presentation for vaginal birth is vertex. Recognizing fetal presentation is essential for safe and effective labor management. The 5 Ps, passageway, passenger, powers, position, and psyche, work together to shape every labor and delivery. Understanding these factors helps nurses anticipate challenges and support safe, positive outcomes for mother and baby. Vaginal examinations are performed during labor to assess cervical dilation, effacement, fetal station, and position. These checks help guide care and determine labor progress. For women without pain medication, these exams can be very uncomfortable. Always explain the procedure and provide support. Vaginal exams always carry a risk of infection. To reduce this risk, limit exams to every 2 to 4 hours unless there is a specific reason to check sooner. When ROM or rupture of membranes occurs, meaning the water breaks, there is a risk of umbilical cord prolapse. This is an emergency. After ROM, perform an immediate vaginal exam to check for a prolapsed cord and begin close fetal heart rate monitoring to ensure the baby's safety. During the first stage of labor, nurses must identify risks and contraindications to vaginal birth, such as placenta previa, active genital herpes, previous classical uterine incision, or transverse fetal lie. In these cases, cesarean section is required to protect mother and baby. After epidural anesthesia, closely monitor for maternal hypotension and fetal distress. Check blood pressure and fetal heart rate frequently and observe for signs of decreased perfusion. The only way to accurately assess contraction intensity is by manual palpation of the uterus. Inform the primary care provider of any abnormal contraction patterns. Assessing fetal heart rate during active labor is critical for fetal oxygenation and guides nursing care. Use a fetal monitor and document the heart rate pattern. The left lateral maternal position is ideal for placental perfusion and fetal oxygenation. Encourage the mother to rest on her left side whenever possible. If fetal bradycardia or sustained minimal variability greater than 40 minutes occurs, this indicates insufficient fetal oxygenation. Inform the healthcare provider immediately. Decelerations in fetal heart rate require careful interpretation. Early decelerations are due to head compression, no action is needed. Late decelerations indicate uteroplacental insufficiency. Variable decelerations mean cord compression. Prolonged decelerations signal fetal hypoxia. Call the healthcare provider immediately. Stage 2 of labor starts when the cervix is fully dilated to 10 centimeters. It ends with the birth of the baby. This is the pushing stage. Contractions are strong and productive, moving the baby through the birth canal. The mother experiences an involuntary urge to push with each contraction. This urge is called the Ferguson reflex, triggered by the baby's head on the pelvic floor. The duration of this stage varies. For first-time mothers, it may last 2 to 3 hours. For others, it is often shorter. Continuous fetal monitoring is required during this stage. Monitor the fetal heart rate pattern in relation to contractions. A normal heart rate is between 110 and 160 beats per minute. Look for moderate variability and accelerations. Watch for late decelerations, severe variable decelerations, or prolonged bradycardia. These may indicate fetal hypoxia. As descent occurs, the perineum stretches and may tear. Tears are graded from 1st to 4th degree. 1st degree involves only skin, 4th degree extends through the rectal mucosa. Prevention includes perineal massage and warm compresses. The nurse supports controlled pushing and prepares for repair if needed. Fetal station measures descent relative to the ischial spines. 0 station is at the ischial spines. Positive numbers indicate further descent. Crowning occurs when the head is visible at the vaginal opening. Birth is imminent at crowning. The nurse communicates progress and provides instruction to the mother and team. In rare emergencies, if a cord clamp is unavailable after birth, the nurse must act quickly. Use any clean string, shoelace, or similar substitute to tie off the umbilical cord and prevent newborn hemorrhage until proper equipment arrives. Stage 2 complications include shoulder dystocia, meconium-stained fluid, precipitous labor, prolapsed cord, and uterine rupture. Shoulder dystocia is a true medical emergency. The nurse must immediately call for help, initiate the Mac-Roberts maneuver by hyperflexing the mother's legs, and apply suprapubic pressure to help free the baby's shoulders. Meconium-stained fluid means the baby has passed stool before birth. The nurse prepares for immediate suctioning at delivery to prevent aspiration. Precipitous labor is birth in less than 3 hours. The nurse stays with the patient and prepares for rapid delivery, ensuring safety for both mother and baby. Prolapsed cord is when the umbilical cord slips ahead of the baby. The nurse uses a gloved hand to relieve pressure on the cord and calls for immediate assistance. Uterine rupture is a tear in the uterine wall. The nurse must call for immediate surgical intervention to protect the mother and baby. Stage 3 of labor starts right after the baby is born and ends with the delivery of the placenta. The uterus continues to contract, causing the placenta to separate from the uterine wall. Signs of placental separation include a sudden gush of blood, lengthening of the umbilical cord, and a firm, globular uterus. The provider applies gentle traction on the cord to deliver the placenta while the nurse monitors for complications. The main emergency in this stage is postpartum hemorrhage or PPH, which is heavy bleeding after delivery. The most common cause is uterine atony, when the uterus does not contract effectively. The nurse must massage the uterine fundus firmly and administer prescribed uterotonic medications. Another emergency is a retained placenta, which means the placenta is not delivered within 30 minutes. If this occurs, the provider may need to remove the placenta manually and the nurse prepares the patient and monitors for bleeding. Uterine inversion is a rare but life-threatening emergency where the uterus turns inside out, causing severe pain and bleeding. The nurse must call for help, start IV fluids, and prepare for possible emergency surgery. In stage 3, the nurse's priority is to watch for signs of hemorrhage and act quickly if complications arise. Stage 4 of labor starts after placenta delivery. It lasts 1 to 4 hours postpartum. Monitor mother for postpartum hemorrhage and vital signs. Assess uterine fundus and vaginal bleeding. Massage fundus if soft or boggy. Report excessive bleeding immediately. Provide comfort, pain relief, and perineal care. Encourage skin-to-skin contact and breastfeeding. Educate on postpartum and newborn care. Document all assessments and interventions.